Without further ado, our first speaker up is someone who needs no introduction from me. All of you will know him, Dr. Drew Provan, one of our medical advisors. And he's going to be talking about how do I handle a patient with ITP. Drew, over to you.
Thank you, Mervyn. And good morning, everyone. Thank you all for coming. I'm the warm-up act before all my learned colleagues speak after me. Okay, where's my remote to change? Oh yeah, thank you. And the laser's on this, right? Thank you. Okay, I'm going to cover a couple of things. One is just briefly on how we diagnose ITP, and then the second part is like what we do about it once we have diagnosed ITP. So low platelets are really common. It's one of our commonest referrals to the general hematology clinic. It's common in the community, GPs see it, we see lots of it in hospital, more if you're infected. But it's not a disease, it's like anemia. I have anemia, but anemia is not a disease in itself. You have to find the cause. If you've got low platelets, we have to find the cause. There's often a cause. And ITP is one of many, many causes of a low platelet count. Obviously, we're dealing here today with ITP, but there are many causes. So the questions we face as clinicians is, what is the cause of this patient's low platelet count? And then once we have the cause, what do we actually need to do, if anything, for the patient? So what is the cause? Well, low platelets, sometimes the bone marrow doesn't make enough, or sometimes our body breaks them down, and sometimes platelets get stuck in places where they shouldn't, like the spleen. So when you do a blood test, the platelet count is low, but they're all hiding within the spleen. These are the main sort of mechanisms. So we treat low platelets and potential ITP like any other medical condition. You have to take a good history from the patient. You have to obviously examine the patient. Of course, during the pandemic, it was slightly more difficult, but we should normally examine the patient from top to bottom and then do some very basic blood tests. And you will know this. We go through a wide list. This is not exhaustive, but we want to know if it's you or if there's anyone else in the family. Have you got any bleeding? How long have you had it for? Is it like 10 years or is it the last week you've had it? Have you had any operations before? Did you bleed badly or teeth removed? Did you bleed abnormally after dentistry? Have you had any infections? Have you been anywhere exotic? Have you had any vaccinations? Have you had any transfusions? How much you drink, obviously, because alcohol, common things are common. People drink and the bone marrow doesn't like alcohol, especially if you drink too much. What's your diet like? What drugs are you on? Because drugs can lower your platelets, and also risk factors for certain viruses like HIV. And then we examine them. You must examine the patient. Do they look well, or are they really sick? Do they look like they've lost weight? Could there be something nasty underlying this low platelet count? Or do they look completely fine? Have they got any bruising? Where is it? Have they got purpura? Where is it? We document all that. Have they got petechiae, red dots on the shins? We should look inside the eyes, because occasionally people can bleed with low platelets behind the eyes, the retina. Can we find any lymph nodes? Is there any evidence of a big liver or spleen? And then once we've done all this, we move on to some very basic, and I do mean basic, blood tests. The diagnosis of ITP is really not very sophisticated, and it hasn't changed greatly for 20 years, 30 years, not much, really. There's nothing, it's just not a sophisticated diagnosis. We need to make sure that the low platelet count that maybe the GP has picked up, is this a real thing? We can't just go on one platelet count. We need to confirm that it is real. So we'll repeat the blood count. We will also look at the blood film under the microscope. We look at not only the platelets, we want to make sure your white cells look normal and your red cells look normal, because if they're not, that might point to another diagnosis. But there is still no test for ITP. ITP remains somewhat depressingly a diagnosis of exclusion. We have to exclude lots of things, and then when we come up with no answers, then we say, well, it looks like ITP. And this is just a blood count. Everything looks fairly normal, but apart from the platelet count of 12, but everything else is hunky-dory. So an isolated low platelet count. And this is the blood smear or the blood film. We spread blood onto a glass slide, and then we look at it under the microscope. If your blood is normal, it should look like this, with white cells and red cells and normal looking platelets. But if you've got ITP, there are no platelets. Well, there are some, but they're hard to find on the blood film. So that confirms that it looks like a real thrombocytopenia. We have to rule out false thrombocytopenia. artifactual thrombocytopenia, which is not very common, but we do see it where the platelets will stick together in certain blood bottles. When the lady takes the blood sample, the platelets stick together and the machine can't read them, and it looks like you have a low platelet count, but actually in your blood, your platelets are normal. This is pseudothrombocytopenia, and you see them all sticking together here, which gives the false reading. That's not common, but we must rule it out. We sometimes, well, we always look for things that might run in the family, familial or inherited platelet disorder. We look for giant platelets the size of red cells. That is definitely a red flag. There's something, this is not ITP. Or very tiny platelets, again, gives us a clue this might be something inherited and not immune thrombocytopenia. And then we look at your white cells. We want to make sure you haven't got something more sinister underlying, like leukemia with very abnormal cells, or myelodysplasia, which is not uncommon, and then maybe angry looking lymphocytes if there's a virus you've had, which might tie in with your low platelet count. And then we do these very basic blood tests, which, as I say, have not changed greatly. We do the blood film, we check your antibody levels, we check your blood group, we check HIV status, hepatitis C, hepatitis B. Occasionally we do bone marrow, and I'll talk about bone marrow in a second. We do another couple of tests sometimes. Well, we always do the antiglobulin test. We occasionally, some countries do Helicobacter pylori. So that's it. That hasn't changed much for a long time. Now, some of you may have had a bone marrow already, because this is what we used to do routinely almost in ITP, but we do them very seldom now, and we have to do them for a good reason. If it doesn't look like ITP, if we think there's something else going on, and if you're not responding to our treatment, we have to think, have we got the diagnosis right? And then we may have to go and do a bone marrow. But it's not a very nice investigation. Certainly I would run a mile if somebody came at me with a bone marrow needle. Yes, Dave Coots is nodding. I would. I mean, I run away from a blood test, so God knows what I'd be like if I needed a bone marrow. But it was routine. In fact, it was routine in lots of conditions, B12 deficiency and all sorts. We'd do a bone marrow. Do you remember? Yeah, in the old days. Yeah, we hardly do them now. So if it looks like ITP and everything else fits and you're all well, then fine, and we can't find anything, and then we just call it ITP. So this is where we are. We've got somebody who is fine, fit and well. They feel fine. They've got low platelets, that's true, and it's real. They've got a bit of bruising, no bleeding. They've got some red dots on their shins. But when you examine them, or when we examine them, there's nothing to find. It doesn't look like anything underlying. This is nothing sinister. We repeat the blood count, and the low platelet count is a real thing. So they really do have low platelets. So it looks like ITP. It doesn't look like leukemia. It doesn't look like myelodysplasia. It doesn't look like a family thing. It's not drug-induced, so it looks like immune thrombocytopenia. So the next thing we have to decide is, what do we do? Now, in the old days, we would often wade in with treatments, but now we're much more gentle, I think, in our management. We have to remember bleeding is the big thing that everyone, GPs, people in the accident and emergency department, they're terrified about bleeding. Oh my God, don't do this, go straight to A&E, something terrible may happen. And people are often told they might bleed into their brain, and that sticks with them. Patients remember this. I may bleed into my brain, but it's not very common. I don't know why people say that. It really frightens a lot of patients, and then we have to calm them down. It takes a while, but we calm them down. But there are other problems that bother you much more. Your energy levels. Nobody really addresses very much your energy levels, the fact you can't do much. Anxiety, depression, worry about crashing counts. There's loads of other psychological effects of ITP, and then of course you've got bruising. But bleeding is a problem. But how can we magically work out who is going to bleed? Can we predict who will bleed? Because that would be really useful. Here's some examples of bleeding symptoms and signs. He would go, this is one of my patients from Southampton with widespread purpura and petechiae right up to the abdominal wall. And this is a patient with a spontaneous bruise on the abdomen, which looks alarming, but obviously will not kill the patient, but it does look a bit alarming. And then you can bleed into the mouth, either the cheeks, you get blood blisters in the cheeks, or you can bleed on the palate, the hard palate here. So, depressingly, older people have a higher risk of bleeding. Now, this is the under 40s with non-fatal and fatal bleeding here. So the under 40s are okay. And then when we get to around 40 to 60, then the rate goes up. So they're higher risk of bleeding from a low platelet count. And then by the time you get to the magical age of over 60 years of age, then of course it goes up dramatically. So there's definitely a big age factor in thinking, do I need to treat? If you're 20, I'm not so worried. If you're 85, I'm a bit more worried about a low platelet count. But you would think that platelets would give us the magical answer, what's my platelet count? But if you look at this is just one study. This is a normal platelet count up here, no platelets here, and this is bleeding from zero bleeding up to the worst bleeding. All the worst bleeding here happened in this study when the platelets were under 10. But that doesn't mean that everyone with a platelet count under 10 is going to have this bleeding, because if you look at all these people, they had much milder and no bleeding with a platelet count of under 10. So it's frustrating, but the platelet count will not predict what will happen. It would be lovely if it did, but it doesn't. So the action plan is we can either do something or not do something. We can observe you, and we will observe you. If you're completely well, if you're young, if you've got no other serious diseases, if your platelets are reasonable and you're not bleeding, and we deem you as low risk, there's no tool for low risk, there's no blood test for low risk. This comes from clinical experience. We just get a feel for whether someone is low risk based on everything we know, everything we've found, all the examination, the history, etc. But we may treat, and we may even bring you into hospital if you're unwell, if you're older. If we think something else is going on, and we need to find out what it is, we may well bring you in. If you are bleeding, obviously actively bleeding, or we think you're very high risk of bleeding, if you've got serious underlying conditions that may contribute to bleeding, if your platelets are very low, rock bottom, especially at the beginning, we will bring you in. So we call you high risk. And again, this is based on lots of different factors we put together, and we sort of come up with a gut reaction in our head. And again, it's largely often based on clinical experience. So what are the options? Well, in the international guidelines that we wrote recently, we decided to lay it out even more clearly, if we can. Therapy should be specific to you at that time. We're trying to prevent bleeding. We're not trying to normalize your platelet count. We're trying to keep you at a safe level, maybe 20 to 30. Some people are fine less than 20. Some people need more than 30. We're trying to use treatments that don't have much toxicity nowadays. We want to move away from things that cause you more problems than the disease, because a lot of the old drugs cause you lots of problems. And we're trying to optimize quality of life. We're paying attention to the quality of your life, which is a big turnaround for medics, because you talk to your average orthopedic surgeon or whatever, quality of life would not even enter their thoughts. But we are trying to think of you and your life, and what we don't want to send you away and make you miserable. The problem is doctors and patients often have different thoughts as to where they want to be. Doctors, we still focus on the platelet count, which is annoying, because I've just told you the platelet count doesn't really tell us much. Safety and bleeding. But patients, all you want is, you want control of your count, you don't want to relapse, you want stability, you want your energy levels to get better, and many patients are happy just to be observed. So we can do that. We can do nothing. Well, I don't mean do nothing, send you away and never speak to you again, but we can not wade in with drugs. We can watch and wait if your platelet count is safe. And that's tough sometimes, knowing what is safe. And that's preferred by many patients, because they're sensible, they live near the hospital, they know what to do. If they get bleeding, they'll contact us immediately and we will see them. So they feel happy not necessarily to have treatment. But sometimes you do have to treat. And I'm afraid it still remains steroids. First line, 1 milligram per kilogram. We suggested a maximum of 80 in the new guidelines, but keep the course short. So give you the full dose for 2 weeks. You respond, that's fantastic. Wind them down over 4 weeks. It's a 6-week course. Compare that with historically when people were on for 4 months, 6 months, 9 months. This is a short course. If you don't respond, well, that's fine. Taper off over a few days, so you got a 2-week course. But most patients are going to relapse. We know that. Most people respond, but most of you are going to relapse when the steroids are stopped. What do we do? Well, we've got these old drugs which we're not using very much, especially during the pandemic. They have lots of side effects. I mean, not for everyone, but there are lots of side effects potentially for these old drugs, and they don't work terribly well. There's no real confidence when we prescribe them. I can't say to you this will work. I don't know. I hope it will work, but I don't know. So we've moved away. In fact, we had a real 3-year period of using non-immunosuppressive therapies during the pandemic. And we had the TPOs that you will know well, we have eltrombopag and romiplostim, and now we have avatrombopag. We have 3 drugs that do not suppress your immune system, that work beautifully well. Efficacy is very high. You ask me if it will work, I'll say yes, they will probably work. You ask me about the old drugs, I'll say I have no idea. I hope they work, I don't know. They are well tolerated. This is from the clinical studies, but in real life, we know that by and large, I know somebody in this audience had a side effect with one who's probably going to say something, but in general, they are well tolerated compared to everything else we had. And the platelet counts rise amazingly, and the bleeding, if you have any, stops. And if you're on a bit of azathioprine or mycophenolate or steroids, you can usually stop that, and the quality of life is better. And 1/3 of patients who have these TPOs, it appears, after a while, if we taper them off gently, we can get you off all therapy. That's 1/3 of patients on eltrombopag, romiplostim, probably avatrombopag too. If we wean you gently, then you will hold your platelet count. I'm not saying it'll be normal, but you'll have at least a safe platelet count on no therapy, which is quite remarkable, but it's hard to predict. So just to sum up everything I've said, thrombocytopenia is very common, but ITP itself is not common. We will investigate you as an outpatient. We don't like bringing people into hospital, but if you're sick, if you're bleeding, if we worry about you, we'll bring you in. Or if your platelet count initially is rock bottom, we'll bring you in. Treatment is pretty urgent if you're actively bleeding, and I mean severe bleeding. I don't mean a bit of bruising. And many patients need no treatment at all. So that's why we've become much more gentle. We know that lots of you don't need treatment. And if we can get away with no treatment, we'll give you no treatment. As long as we've got a good relationship and you know how to get hold of us, then that's fine. But if we absolutely must treat, we do nowadays try to use something that we feel will work, will not cause you major problems, and will not make life miserable for you. And that's a big change from 5 years or so ago, when we were very limited in our therapies and we knew they had side effects. So it's a different world for ITP nowadays, and it's going to be interesting to see what happens as we have come out of the pandemic, what's going to happen to prescribing in terms of the nice drugs like the TPOs and the old drugs. Are they going to start making a reappearance because of funding and other issues? But anyway, with those thoughts, I will stop, and thank you very much for your attention. And I'm under time. I probably went so fast nobody can understand what I'm saying. You will be too. Dr. Semple will be too.
Just put your hand up. No? Well, that's the first time ever.
I think he's got a question. Have you got a question for me? Yes, it better be a nice one. I want a nice question.
Is there a book or a write-up or send your slides or something that was really interesting?
The slides are on. I mean, I can give. In fact, I've emailed them to Mervyn already. I'm very happy if you want.
I will
a copy
be publishing the slides.
Okay.
Yeah, okay.
But you can send him personally a copy. I'm very happy to use for a copy of my slides.
What I would also
that's a nice
say
question. I
is
like more like
that in your packs, you should all have a copy of the shared decision-making document that the association produced.
Yeah, but my slides are nicer.
With the help of all of our medical advisors.
Oh, Professor Newland, yeah, you'd be trouble. Yes.
Sorry.
I was just going to ask a simple question. You've talked about treating the patient with ITP, Drew. Would you differentiate, I know you're not a paediatric haematologist, but would you differentiate your handling of kids as opposed to adults?
Well, no, that's a good question, and I think a lot of the way that we treat adults now has come about through looking at our paediatric colleagues, who are very hands-off with ITP compared to us. We were very aggressive treaters. I'm not looking at you specifically, or maybe I am. But we used to treat people much more and say, how come they get away with it? Because they go by symptoms. If they got no bruising or bleeding, they don't bother doing a blood test often, and because the kid is fine. So I think in that sense, I think backing away and just taking things. There's no major rush with ITP. There's hardly ever a major panic. And the paediatricians, I think, have shown us that. And I think we've learned a lot through that and through the pandemic. I think it's changed our whole approach to aggressive therapy, rendering people immunosuppressed. trying to achieve some target goal, which is very nebulous, and we've never really agreed properly what we're aiming for, and we all have different things in mind. When I started way back, before I joined you, before I was reformed by the London, I used to try and get the platelet count normal. I did. I thought you'd try and get a normal platelet count. I thought that was the goal, because I didn't know much about ITP. It's stupid to go for that. I mean, it sounds silly now, but I'm admitting it. So I think our goals are realistic now compared to before, and a lot of that's come from the paediatric colleagues. I don't know if that answers the question.
Okay, any other question at the back, sir? Hold on.
Yeah. Previous use of steroids.
Hold on, my hearing's not very good. I need a deaf aid.
Does previous use of steroids in a patient compromise use of the more modern therapies?
Sorry, can you just...
Does the previous use of steroids in a patient compromise the use of
No, not really. No, steroids are still the routine first-line therapy at the moment because of the speeds, and so everything we do is usually post-steroids. You would hardly ever get to another drug having not tried steroids initially, and using steroids up front is often a diagnostic test in a way, because if you don't respond to steroids, we wonder whether there's anything immune going on. It doesn't sound very immune if you don't respond. So for us, it's slightly a diagnostic test, and it is our first line, and then so it doesn't really compromise anything particularly. No.
Okay, is that it for one question here?
Okay, I'll get a seat. I'll just sit there.
My wife is using romiplastin.
Right.
Initially, we started off injecting every 7 days to keep the platelet at a reasonable level. Over time, it's progressed. The same injection, 7 days, 14 days, 20 days, 21. So what you're saying is one can actually start reducing.
Absolutely. What she's experiencing is because when we first started using it, the first 6 patients we treated, we had 2 or 3 who we did a weekly thing, but then it seemed too much, so we stretched it out to 2 weekly, and that was great. So we went to 3 weekly, 4 weekly, and then we suddenly thought, actually, why don't we just stop? And then we stopped, and they've all been fine. So that's because initially we thought everyone needed it like weekly and forever, but that's not true. Everyone needs something. So the fact that she's needing less and less and less and less, at some point, quite soon, she should maybe get the dose down as low as possible for a little while, then give a trial of no drug. If she relapses, she can go back on. It's not a big deal. It's worth trying. Yeah, the best drug is no drug.
Okay, thanks everyone. Right, thank you, Drew.